All right, so today we will talk about the fluids electrolytes and the acid-base balance, like we call it ABGs. So the question was where the fluids are located in our body in the different compartments. So one said the interstitial fluid. Where else we have fluid in our body?
Our bladder.
Okay, but in terms of not cavities, we're looking for fluids. No, this is
Our
the
cells.
this is the byproduct. Yeah, so it's in the cells, inside the cells, which is intracellular. We call it inside the cell intracellular, which is ICF. And then we have it outside of the cell. So there's a large amount of fluids in the human body that is accounts, it depends on the, according to the age group, between about 70 to 80% of the body weight that's in which age group? Who would have more fluids? Children or older adults, or like adults or older adults? Who would have the 70 to 80%? Imagine 70 to 80% of the weight, of the body weight, is fluids. Who would that be, the older adult or the infants?
The adults.
No. Who would be at high risk for dehydration is the older adult, right? Because they have 55% or 45 to 45% of body weight. So the 45 to 55% of the body weight of water would be in the older adult, and then the 70 to 80%, most of their body is mostly fluid, which is in the infant. That would be infants of 70, who has 70 to 80% of body weight. That would be the infants, and then the 45 to 55% of body weight in older adults. So the fluids are located inside the cells, intracellular or extracellular, which is outside the cell, in two places. You can call it like sub compartments. And then we have another place called transcellular fluid. So these are compartments, like three places. You can call them like three rooms, three places, three areas in which the fluids are located in our body. Inside the cells, outside the cell, which is either in the blood, in the plasma, in the blood vessels, which is called intravascular or vascular. You can call it vascular or intravascular. And we have the transcellular, which is, the interstitial, which is still, it's called extracellular, which is the fluid that is between the cells and the blood vessels. So between blood vessels and cells, there is space called interstitial space. And the third compartment, place, room, in which the fluids are located is the transcellular fluid, like cerebrospinal fluid is one of them. The fluid in the joints, synovial fluid, also transcellular fluid. The fluid around the lungs, there is small amount of fluid around lungs between the pleural lining and the visceral lining. That's also part of the transcellular fluid. The fluid in the abdomen, it's called the peritoneal fluid. So all of these are, it's small amounts, but like 1 liter of fluid. It's called transcellular fluid. So these are the three places in which the fluids would be located in the human body. So the interstitial fluid accounts for 42% of body weight, which is the fluid located inside the cells. And most of the prevalent cation, we have sodium, we have potassium, we have other electrolytes, but the most important two are would be the sodium and potassium. We'll spend some time, or most of the time, talking about the sodium and potassium, given the importance of these two electrolytes. So most of the prevalent cation, which one would be more present inside the cell? Sodium or potassium?
Potassium.
Potassium. So we have more of the potassium. We have both sodium and potassium inside this intracellular, but the most of the potassium will be inside the cell, intracellular, not extracellular. The extracellular one will be the sodium. So we have interstitial. Again, we have the other compartment in which we have fluids. About 20% of body weight will be extracellular. So imagine that 40% of that fluid will be inside the cell, and then only 20% will be outside, which is in either interstitial or the vascular compartment. So vascular space, blood vessels, and interstitial space, both are called extracellular fluid, ECF, and they account for only 20%. So you see the whole, that blood of about like 5 liters of blood and other fluids, interstitial space, in the interstitial space, all of that only 20%. But most of the fluids will be inside the cell. About 42% of body weight will be inside the cell. So if the patient weighs 70 kilograms, they would have 30 liters of fluid inside the cells, intracellular. About 2/3 of the body weight will be inside the cell, intracellular. So the transcellular fluid, when I give examples, approximate, we have about 1 liter of fluid called transcellular, and that's present again in the places like CSF fluid. It's belong to this compartment. GI tract, fluids in the GI tract, the small intestine, large intestine, the fluid there, or also like secretions and fluid, it belongs to this compartment. Synovial fluids in the joints. Peritoneal fluid in the abdomen also belong to this compartment. So we always talk about the homeostasis. So what makes the fluid, or we have two different compartments, two different places. What makes the fluid to be in a homeostatic or in harmony in terms of like balance between intracellular, extracellular, in the interstitial space, and we have three main compartments, and the extracellular fluid, it has two subcompartments, like we have vascular and interstitial. So you have like 1, 2, 3, about 4 places in which the fluid is located. So what makes this, the fluid to be in terms of balance between all these 4 compartments? What do you think some of the abnormal or alterations to this balance? If you didn't have balance of the fluid distribution in the different compartments, what would happen? What examples? What would you think? Think of examples of fluid alteration in terms of the fluid distribution, and that patient has some type of imbalance in terms of the fluid distribution in different compartments. An example of that. What do you think?
Edema.
Yes, edema is the major one.
A fluid in the lungs when you have like pneumonia.
Yes, pneumonia, edema, pneumonia, the pleural effusion when you have fluids around the lungs. Fluids collected in the lower extremities, like in the pitting edema in patients with heart failure. Electrolyte imbalances when the patient's potassium level rises because of the kidneys unable to excrete potassium because of the failure, or the liver unable to, liver cirrhosis or liver problems in which the liver is unable to produce proteins. And that's when the patient also develop the hypoproteinemia and the edema as well, because the edema will result from the low protein level in the blood. And we'll talk about these, why the patient with hypoproteinemia will develop the edema or the swelling. So the forces that govern what makes all that, the balance, or bring, all this, balance between the compartments in terms of fluid distribution. And healthy people, they do not have edema, no pleural effusion. They don't develop fluid to be retained in the abdomen, and they will have like 5 liters of fluid in the peritoneal space in the abdomen.
Ascites?
Ascites, good, perfect. Yes, ascites. So they don't develop the ascites. So all of these are, so the healthy people. So the factors that govern or control the fluid distribution, we have about 6 of them: osmosis, diffusion, facilitated diffusion, active transport, hydrostatic pressure, and oncotic pressure. These are, so it's this is the time to to understand the 6 factors, because you are going to apply this to almost like all diseases that involve the fluid imbalance and electrolyte as well. Like when we discuss the renal failure, we will go over some of these factors that control the fluid distribution. Liver cirrhosis, same thing. Cardiac, heart failure. So you know this from like chemistry and from the other classes like biology. So it's just very quick review of the difference between osmosis and diffusion. How would you differentiate between osmosis and diffusion? And all of these are the factors that are going to control the movement of fluid between these compartments. When there is a problem with one of these forces, then the fluid imbalance and electrolyte imbalance would result. So, and the difference between osmosis and diffusion?
Osmosis is just with water, right?
Right, which means that it allows the govern or control the movement of the water between 2 compartments, because the membrane has to be permeable membrane to water, but it doesn't allow any molecules or solute to pass through, right? But with diffusion, it is the movement of the molecules or the solute from the area of high concentration to a low concentration. So just remember this, that the osmosis has to do with water movement, and the diffusion, it controls the molecule movement. And it has to be that, what determines this is the membrane. Is there a membrane or not? And if that membrane is permeable to water only, or it allows solute to pass through. So osmosis, water movement; diffusion, molecules or solute movement. The facilitated diffusion, which is the specific carrier molecules involved to accelerate the diffusion. You need some type of another force or another factor to accelerate and to move the molecule. For example, the movement of glucose molecule into the cells. Who would be responsible for the movement of who will push the glucose into the cells to be metabolized? And because if the glucose molecule stays in the blood, then the patient will develop a hyperglycemia, like patients with diabetes. So which factor or which hormone will push the glucose inside the cell, will take
Insulin.
insulin, yes. So this is called facilitated diffusion, an example of this force. The active transport. So the active transport in which that the molecules move against concentration gradient. And this, it's called active transport. Active means we need some sort of energy. And the energy you learn in chemistry, there's something called ATP, adenosine triphosphate, right? The adenosine triphosphate, which is a source of energy, that what makes the, see on the right top side of the corner of the slide, it's the sodium potassium pump. The sodium potassium pump, which allow for, see that pump, ATP, and then they have potassium and sodium, two arrows of potassium and sodium, and then the pump. This pump needs the ATP to work. It's like a water pump. You need some electricity. You have to, plug it in, with the electricity in order to make it, working. So in order to make the pump works, you need some ATP as a source of energy. In the absence of that ATP, which leads us to, to the previous session, which is the cell adaptation, which mean, when in which that the cell, it doesn't have enough energy like ATP, it will result in the death of the cell. So what's the sequence of energy depletion that will result in death of the cell? The sequence or sequence of events will start from the ATP, absence of ATP, of the energy, will make this pump to fail. So the failure of the pump will result in the sodium will be gushed into the cell. So because this pump is supposed to regulate and control of the sodium and potassium, most of the potassium inside, it keeps the potassium inside the cell, and most of the sodium outside of the cell. If this pump fails, then most of the sodium will enter the cell, and we know that from chemistry, what follows the sodium. When you have, anytime you have a salt or sodium, then the water follow all the time. So the more sodium entering the cell, which result in more fluid or water is going to get into the cell. So which would result in the swelling of the cell. And that swollen cell could result in rupture and then death of the cell. So this is like one example of the sequence of events when the energy when ATP as a source of energy, like energy depletion, would result in the cell death because of the fluid getting into the cell. So this will lead us to differentiate between the hypotonic, isotonic, and the hypertonic solution. So the hypotonic solution, what makes the solution hypo or hypertonic or even isotonic?
Depends on the amount of solute in the fluid.
Right. So the solute, which is the molecules, more molecules, it's more concentrated. And it has to be in relevance to something else. So it is concentrated in comparison to what? So here we are all, so this, right here, this solution, when I say, so these are the molecules and the water here. This is the concentration of the, let's see that, this is the RBC, red blood cell. And this is the vascular system blood vessel. So this is the blood, this is the plasma, and this is the cell. So if this is high, less concentrated than the cell, so we have more molecules or solute or molecules inside the cell, that makes it here is more concentrated than the plasma. So here the solution, this one right here, which is the plasma, will be hypotonic. Hypotonic. because it is less concentrated than the cell or the intracellular. So when it's hypotonic, we have the hypotonic solution or the hypotonic plasma here, and you can apply this to any fluid, not just the plasma. Also, we have urine. We have specific gravity, for the urine. We have osmolarity for the urine, or osmolarity for the urine. Same thing for the blood. Plasma osmolarity, which means the concentration. When you say osmolarity, it means concentration. So high osmolarity means concentrated. And we have reference, like numbers and ranges for, for osmolarity when it's concentrated or versus it's diluted. So it's here when let's just, I'm gonna give an example of that. That this is the blood, this is the plasma, and this is the red blood cell. So if the plasma is diluted, so then we have more water than the molecules. So the fluid's supposed to enter the cell from the low concentration to a high concentration because it's hypotonic. And the other side, with the isotonic, it's equal concentration inside the cell and outside the cell. So there's no more. So the fluid will be in balance, will be in the concentration equal on both sides. So there is no any exchange of fluids in terms of water here. But when it's hypertonic, because the plasma is concentrated, so it needs more water. So it has more molecules, more solute, more molecules. So the concentration, it has to do with two things: molecules or solute and the water. So if it's concentrated, which means we have lots of molecules but small amount of water. When it's diluted, we have a small amount of molecules and too much water. So that's the best way to understand the isotonic, hypo, and hypertonic solution. Because each compartment tries to reach the balance and the concentration to be equal, so to equalize the concentration between two compartments. The movement of the water will make that, or will make that objective of reaching the balance to be equal between the compartments. So fluid will move from place to place, or from between the compartments to reach the balance. Now the solutions, as you know, that some solutions are listed or considered as isotonic, and others as like normal saline, which is 0.9% saline, which is the isotonic. And the concentration of our plasma is considered as isotonic. So when you give the patient, or when you administer the IV intravenous fluid of not 0.9 normal saline, it's not going to do any changes in terms of the fluid distribution or movement of fluid from compartment to compartment. Or what it does is just it will that flow is going to stay in the bloodstream. It's not going to move to the cells, or it will so it's isotonic. The 0.45%, it's hypotonic. And we have also, we use this mostly for children. We have also this is half, what do you call it, this half normal saline. Half normal saline. We have also a 1/4 or 1/4 of normal saline, which is 0.225, like this one. 0.225. This is 1/4 of normal saline, but this one is 5% with 1/4 of normal saline, which is isotonic. Ringer's lactate is isotonic, and mostly we use this one because it has lots of electrolytes. We recommend it for patient with electrolyte imbalances, or deficiencies, and also for patients with burn injuries. hypertonic would be the 10% in water that will be a hypertonic solution. The 5% is still, it's isotonic. Even if 5% disclose, like a D5, we call it D5W, that's the D5W, that's the still isotonic. Higher than 5%, like 10% glucose, that's hypertonic. So the pressures that govern the movement of fluids back to the forces that control the fluid movement: osmotic pressure, hydrostatic, oncotic pressure. Did you cover this in EMP, or you cover this from anatomy and physiology classes? Anyone remember this?
Yes.
So, so the osmotic pressure determined by the amount of solute or the concentration of the molecules. The more molecules, will give it more pressure. The hydrostatic, it's the force within the compartment due to the volume. So when the volume of blood has increased in that organ or compartment, then it's going to push the fluid out. Same thing for the osmotic pressure. It will push the fluid or the water out. Oncotic pressure is completely different and is going to pull the fluid into the compartment. So the oncotic, we call it oncotic colloidal pressure or oncotic pressure. And oncotic pressure, what makes the pressure is the presence of the proteins. The protein molecules will exert or produce this type of pressure called oncotic or colloidal pressure. So you will have this scenario constantly in the nursing homes, and older adults who would develop an edema, swelling of the, let's say, like right hand. And we can, sometimes we cannot figure out what exactly happened with the patient. Just, the edema resulted. And then as we continue to follow up or, investigate, we'll find that the patient or the older adult has a hypoproteinemia. Their protein level is low. And that's the reason why the fluid had moved out of the blood vessels into the interstitial space. And that's exactly what the swelling of the edema is, which is the fluid had, movement from the vascular compartment to the interstitial space. So why the fluid was pulled from the vascular compartment to the interstitial space is because the patient doesn't have enough protein molecules in the vascular system. So we need the albumin, the albumin and the proteins, molecules to maintain the fluid or the water inside the vascular compartment or inside the blood vessels. So the colloids or the proteins, which is the oncotic pressure here, the protein pull the fluid in or pulls the water into the compartment. Osmotic and the hydrostatic, it will push the fluid out. So the increased pressure, like in hydrostatic, increased pressure is going to push fluid or the water out of the compartment. Osmotic pressure, the same thing. But the oncotic pressure or the colloidal, because the protein, it pulls the fluid into the compartment. So osmotic, hydrostatic, push it out. Oncotic, colloidal, pulls the fluid in. That's the easy way to remember that.
So what does it mean when the lab report shows the albumin protein that's a high or low?
Yeah, when it's low, that's the problem with the hydrostatic pressure. Yeah, it's hard to see it, high, but it's, mostly it will be hypoproteinemia. So osmolality which is the concentration of the solution. And here we talk about most in the human body. We look at osmolality of the plasma, osmolality of the urine. That's mostly will be concerned about. And most of the time we talk about the plasma, the blood, more than the urine. So the osmolality of the plasma supposed to be between two numbers with the reference ranges 295 up to 275. Some textbooks, they refer to the high, to the higher limit as 300 instead of 295. But you can just, we can adopt this 295, 275. The lowest to the highest is 295. So what does that mean if the osmolarity of the plasma is less than 275? It's less than 275. So what's the definition, or how would you explain that? If the patient asks you, my lab shows that this number 275, how would you explain that?
I would say it's concentrated too much
Less than 275, less.
The particles are diluted.
So it's the opposite, Cindy. When it's diluted, so the higher the number, the higher the concentration.
Okay.
Good. So the higher the number, the higher concentration. The lower the number is, so less than 275. The lower the number is the dilution. It's more diluted.
Like too much water.
Good. Yes. So less diluted. I'm sorry. The lower the number, it's more diluted. The higher the number, it's more concentrated. So less than 275, it's highly diluted, which means that dilution means we have two main things. We have molecules and we have the water, right? So if it's diluted, then which we have in excess? Is it the water or the molecules?
The water.
The water. So less than 275, it's water excess or overload, fluid overload, in other words. And if it's higher than 295, it's concentrated. So we don't have enough water. So we have most of the component of that plasma or the blood is molecules, and we don't have enough solvent, which is in this case the water, right? So
Professor,
yes,
the normal value is 275
to 295. It's a range.
Okay, 275 to 295 is the normal value.
Yes. Yeah. Yeah, we call it normal value, and sometimes people don't like to call it normal. They will call it within defined limits. Others will call it reference ranges or reference numbers. So either way, you can call it reference ranges, normal values, within defined limits. It all refer to the same thing. So these are examples of how edema would develop. So fluid exchange or fluid balance and exchange between the compartments. So the fluid or the water is going to exit the blood vessels. So the shift out of the blood vessel and result in edema because of these are three examples, because of the elevation of venous hydrostatic pressure. Remember, the hydrostatic pressure is going to push the fluids out. Increased pressure, hypertension, for example. That's an example of hypertension and edema. Patients with liver cirrhosis, they will develop this too, because the portal vein becomes blood stagnant and accumulates in the portal vein in liver cirrhosis, for example. So then the fluid will accumulate in the portal vein, and fluid will be pushed out because of the hydrostatic pressure has increased. So that will result in the increase of hydrostatic pressure, and that will push the fluid out. And that's when the patients with liver cirrhosis, would experience the ascites and fluid accumulates in the abdomen. Anyone ever saw a patient or had a patient with liver cirrhosis with abdomen, protruded in a large abdomen, fluid collecting the abdomen? Anyone? Saw a patient with liver cirrhosis with
Yeah.
ascites? Yeah.
Yeah.
Yeah, you will be stunned with with the protrusion of the abdomen and the how much fluid is collecting in the peritoneal space and how big is the abdomen in the patients with liver cirrhosis. And when we do the aspiration of the fluid, you can take thousands of milliliters. In other words, like 4 or 5 liters of fluid from the abdomen. So because of the hydrostatic pressure. So, or because of remember we talk about the protein molecules in the vascular system. If we don't have enough molecules or protein, hypoproteinemia, that will lower the oncotic pressure and it will no longer hold the fluids in the vascular compartment. So fluid will leak, fluid will be pushed out. So the oncotic pressure pulls the fluid in, but if we don't have enough molecules of protein molecules, then the oncotic pressure would decrease, and the decrease in this pressure would result in allowing fluids to leave the vascular compartment because the protein is supposed to pull the fluids in. We don't have enough, fluid will leave. Elevation of interstitial oncotic pressure. You can apply the same principle of that, oncotic colloidal pressure to the interstitial space. If you have lots of protein molecules in the interstitial space, like in burn injuries, patients will be edema. They will develop the edema and swelling, and that's because of the destruction of the cells and the protein molecules in the interstitial space is going to pull the fluids in from the vascular compartment. So fluids will be pulled from the vascular into the interstitial space, and then the edema would result. So these might seem very kind of complex and difficult, but it's just you have to really live with these 3 factors or 3 forces. Try to write down something about this is a vascular system, and this is interstitial space, and this is the force, hydrostatic pressure, this is the oncotic pressure, and look at and try to understand the nature of the pressure and the source of that pressure. Hydrostatic, what makes the hydrostatic pressure or what forms the pressure? It's the volume. The oncotic pressure, colloidal, it's the protein molecules. Hydrostatic push the fluid out. The colloidal pressure, oncotic pulls the fluid in. So it's sometimes a little confusing, but I think you have to really spend some time, study or read about the pressure, because it can it makes all processes after that much easier once we became like proficient to understand the 3 forces, because these are the main forces that govern all the fluid shift and movement in the compartments. So the rest of the upcoming slides, it's more of EMP and anatomy physiology. In terms of that, it talks about the hormonals, like the hormones. Not this slide, the upcoming slides, but this is just an examples of when the elevation of the hydrostatic pressure. I'll give you some examples of that, clinical relevance or clinical examples. Decrease in plasma oncotic pressure, elevation of interstitial oncotic pressure, and the last one here, it says the interstitial space or interstitial fluid to plasma. Now this fluid will move from or shift from the interstitial into the plasma. Interstitial to the plasma. This fluid will enter the vascular system, in other words. It will enter the vascular system. So what makes the fluid to enter the vascular system from from the interstitial space. So two things. Either there is an elevation of the interstitial hydrostatic is going to push the fluid out from interstitial into the plasma. And that's something can be an example of that therapeutic. We do that because in patients with lower extremities edema, we want to push the fluids from the interstitial into the vascular by applying, what would you do in this case? Especially like people with varicose veins and they have edema in lower extremities, pregnant women, there are different like examples of cases. What they usually do to push the fluids and prevent the edema.
You use a hypertonic solution?
No, I'm not looking for a treatment here. It's more of the application, and that's very common, and most people use it.
They have the
Compression socks.
The wear, yes, compression, so yes, the TED stockings, elastic compression stockings. Yeah, so they apply the TEDs or TED stockings as therapeutic action for this effect, or because this fluid shifted to the plasma or to the vascular system because there is an increase in plasma oncotic pressure or osmotic. So the oncotic pressure in the plasma has increased, so it's going to pull the fluid in. So the patient takes a large amount of colloids or protein or dextran, like one of the drugs called dextran, or hypertonic solution, as I said, in this case, that will shift the fluid into the vascular compartment. The fluids in our body is distributed in three different, distributed normally in a normal distribution among the three main compartments. And anytime we have the normal distribution of the fluid in the three compartments, we call this first spacing. Anytime the fluid is going to be shifted into the interstitial space and we have like edema, we call this second spacing. And it's very easy to be treated. We give Lasix, diuretic medications. So you have different therapeutic modalities and things you can do to correct the second spacing. It will respond, so it is responsive to medications. Third spacing, it doesn't respond to meds. Because third spacing is a fluid that is trapped in the compartments. Fluids that is like when we said ascites, which is the accumulation of the fluid in the peritoneal space or cavity. This fluid, and it's just an example, just give you one example because I can give you lots of examples. This is just an ascites is the perfect one. Because the ascites, if you give patient diuretics, I think the ascites will be refractory. It will respond to the medication. So you cannot resolve the ascites just by giving the patient meds like the diuretics, like these furosemide, Lasix. So the third spacing in terms of fluid trapped in the cavity or in the body part has to be removed mechanically, like fluids in the joint, for example. If there is a lot of synovial fluid in the right knee, the meds will not help with that. Same thing with the ascites. You have to physically remove and aspirate the fluid. So that's the third spacing, in which that the fluid is trapped, is collected in the joint or in the cavity, and then it has to be removed mechanically. So we have something in the treatment and the or procedure to remove the fluids from the abdomen or from in patients with ascites, and we call this. Does anyone know what it's called? The procedure to remove fluids from the abdomen. Aspiration of fluids from the peritoneal cavity is called paracentesis.
Paracentesis, yeah.
Yes, paracentesis. So paracentesis, which is a procedure you will learn about, in Adult Health 1 about this one. And it's the procedure in which the trocar, which is like a large needle, is going to be inserted in the abdomen and then will aspirate the fluid. So that's paracentesis. And we have also another procedure for the lungs. If there is a pleural effusion fluid around the lungs and we want to remove the fluid from around the lungs, we call that thoracentesis. So these slides are pure anatomy and physiology. So it talks about the regulation of water balance in terms of the hormones and other and certain factors like the pituitary regulation, adrenal cortical regulation, like the cortisol, steroids, and the aldosterone. The most important one here, which is aldosterone, it controls to a large extent, significantly the fluid and electrolytes, especially sodium and potassium. So let's just talk about the aldosterone, just to remind you with some EMP. So aldosterone as a hormone, aldosterone, what's the function of aldosterone?
It regulates salt and water.
Right. So what exactly it does? If you let's say that you have patient will have a increased secretion of aldosterone, hyperaldosteronism. How would you describe the patient in terms of the fluid imbalance in patient with hyperaldosteronism?
Is it retaining more sodium or something like that?
The aldosterone, what it does? What's the function?
It regulates salt and water.
Right. But what exactly it does in terms of the sodium and potassium?
Your body loses too much potassium, right?
So high aldosterone. So it's increased aldosterone will result in
loss of fluid.
Accumulating more sodium.
Okay, so it's, I'm sorry, Amy.
Cell destruction due to too much or too little fluid because it's not being regulated.
So the aldosterone, it will retain sodium and excrete potassium. Sodium retention and potassium excretion. So that's what it does. It will retain sodium and potassium excretion. So the hyperaldosteronism, patient with hyperaldosteronism, they will have the fluid and sodium retention and potassium excretion. In other words, that it will have fluid overload and the hyperproteinemia, hypernatremia, and hypokalemia. And there is also a cardiac regulation because of the ENF hormone has another factor, another mechanism to control the fluids, GI regulation, and then the insensible water loss that's like from perspiration and sweating. Hypo and hypervolemia. So we're not going to focus much on the treatment of the hypo or hypervolemia. Just focus on the pathophysiology of it. electrolytes. So this is one of the ways of describing the electrolytes in the chart. We call this BMP, basic metabolic panel, BMP, and it includes all the electrolytes, BN, creatinine, and the glucose. So the sodium, so we need from this, if you don't recall the normal ranges or reference ranges and numbers for the electrolytes, this is the time, to remember them, because we need to know the ranges in order to be able to answer the questions. And same thing with the ABGs also. We need to know the numbers. So for sodium, it's 135 up to 145, potassium 3.5 up to 5.5, calcium it's 9 to 11, and we are concerned here with the calcium ionized, the ionized calcium, which is about 50%, which is the active form. The active form of the potassium is about half of that number. 9, half of that is 4.5, half of the 11 is 5.5. So the ionized calcium is the active form of the calcium. It's about 50% of the total calcium. And then the bicarb, chloride, and protein. Sodium hypernatremia, and that's when the sodium level is over 145. And the hypernatremia causes hyperosmolarity, leading to cell dehydration. So patients who develop the hypernatremia, they tend to have more molecules and less water. So that will result in that they will end up with cell dehydration inside the cells. And what protects us from developing this hypernatremia, healthy people, is that anytime you feel you are thirsty, you're going to drink water. So that will protect you from the, developing the hypernatremia and dehydration. So these are the manifestations of hypernatremia: thirst, neurologic changes, agitated, lethargic, at some point may result in seizure attacks or coma. And this is like a continuum of signs and symptoms. Doesn't mean like all patients with hypernatremia will develop all of these. But on the scale of 0 to 100, the lowest will be like, weakness, and then higher than that will be lethargic and agitation. Then the last thing, or the highest, would be high extent, would be the seizures or coma. So it's like in a continuum. It doesn't mean that patients with hypernatremia will develop all these symptoms at the same time. So usually we will treat the underlying cause when it comes to hypernatremia. And if we correct the hypernatremia, the sodium levels in the blood, serum sodium levels, should be reduced gradually. So patients with hypernatremia would try or attempt to give fluids in order to gradually decrease the sodium level. So if we give IV solution of 5% dextrose, or do you want to give hypo or hypertonic solution in this case for patients with hypernatremia? So we give hypotonic, right? You give hypotonic, so you can pull more sodium from the cells into the vascular compartment. Hypotonic, to pull more electrolytes or sodium from the cells into the vascular compartment. You want to give hypotonic. So if you as you reduce the serum sodium levels, try to reduce them gradually, because if you do that fast or abrupt or sudden, accelerated way of reducing the sodium levels in the blood, that could result in what is called cerebral edema, like edema in the brain cells. And we'll talk about this more in the cerebral edema under the neuro system. Hyponatremia, which is a common problem in patients who take the diuretic medications, take meds for diuresis, like furosemide, Lasix, aldactone, spironolactone, aldactone. And if they already, being on low sodium diet because they have hypertension, or they have, the renal failure, or they will be already on low sodium diet, and they will take, and they are on concurrently taking these medications that will even lower the, the sodium level to a lower level, limits, so on numbers. So the patients may experience these symptoms, mostly GI. In addition to the neurological ones like confusion and seizures. Now, the potassium electrolyte, another important electrolyte, which is necessary for all of these mechanisms, mostly transmission and the conduction of the nerve impulses. And that's why patients with the hypo or hypernatremia, they experience the muscle twitching and the weakness of the muscles and the muscle spasms and all of these signs because of the skeletal muscle contraction and because of the conduction and the numbness and one of the functions is the transmission and conduction of the nerve impulses. It's also important for the maintenance of the normal cardiac rhythm. So patients with hypo or hyperkalemia, they tend to develop a EKG or what is called the dysrhythmias. So sources of potassium that could result also in addition to the fruits, for like food, but also it's the source of that could be stored blood, especially for those who receive multiple blood transfusions. They could develop the hyperkalemia from the stored blood because from the destruction of the RBCs, because most of the potassium inside the cell. So the destruction of the RBC that will result in more destroyed RBCs result in releasing more potassium in the bloodstream. So the hyperkalemia, anytime potassium level is over 5.5, and that would, patients who would develop this or experience this will be an example of that renal failure patients, because the kidneys won't be able to excrete the excess of the potassium. So patient will retain potassium. Patients who take a potassium sparing diuretics, like patients on spironolactone, which is aldactone, one medication that cause diuresis. At the same time, it will keep the potassium level and will not affect the potassium. It will keep it. In other words, that it will not result in losing the potassium due to the diuresis, because we have another medication called furosemide, Lasix. It is potassium losing. It allows fluid to lose, to exit, so it will cause diuresis. In addition to that, it will take also the sodium, the potassium with it. So it will take potassium with it. So urine and potassium. So that's why patients on furosemide diuretics, furosemide Lasix, supposed to be on at the same time concurrent with this drug, they should be on potassium supplement. They will be on a 10 milliequivalent or 20 milliequivalent, depends on the dosage of the drug they are taking. So the hyperkalemia could result from the potassium sparing diuretics, not from the potassium losing. Potassium losing, patient tend to develop a hypokalemia. So it depends on the drug. Is it potassium losing or potassium sparing diuretic? Well, in terms of hyperkalemia, the treatment, we will talk about this in, in adult health 2 and 3, and what are the nursing implications and implementations to lower the hyperkalemia, like medications called K-Xylate, or give diuretics, or you give the calcium gluconate, calcium bicarb, or you give the IV insulin drip with glucose. All of these are modalities to lower the high potassium level. Now, hypokalemia, in which that anytime the potassium level is less than 3.5, that is called hypokalemia. See how the increased aldosterone secretion will result in hypokalemia, because this is the function of this aldosterone hormone: sodium and water retention and potassium excretion. It will allow lots of potassium to be lost in the urine. So that's why when the aldosterone level increased, more potassium will be lost, and that results in hypokalemia. Manifestations, EKG changes. So the EKG, in terms of dysrhythmias, could result from either one, hypo or hyperkalemia. Now, increased digoxin toxicity, you will learn about this in form next fall. And it's just to keep in mind about the digoxin toxicity, patients on medication to improve the pumping ability of the heart, which is called the cardiac glycoside, or medication to maintain the normal function of the heart in patients with heart failure. It's called digoxin. We should be careful with, when we put the patient on digoxin while on another medication to lower that would lower the potassium level, like the Lasix, furosemide. So just keep this, like sentence, that the hypokalemia precipitate or trigger the digoxin toxicity. So the toxicity would result from the when the patient is hypokalemic. When the potassium level drops lower than 3.5 and patient already on digoxin that morning, if the patient's you found that the potassium level is 3.2, you need to hold the digoxin that morning. Don't give it, because that could result in toxicity if you give that digoxin that that morning. If you administer it to the patient with hypokalemia, that could result in digoxin toxicity. And this is one of the most important concepts in pharmacology when it comes to digoxin toxicity and hypokalemia. So hypokalemia triggers the dig toxicity. The potassium, keep in mind that this is one of the most important concepts which pertains to potassium, is that potassium should not be given IV push. Right? Is this known to everyone or something new, some of you? Potassium?
Because it will burn the IV.
Yeah, because the potassium it causes the cardiac to stop working, right? It will cause what is called cardiac arrest. You can kill some, can kill a patient if you give the IV push, potassium IV push. If you give IV push, potassium via IV push, it can kill the patient because that results in a cardiac arrest. We call it cardiac cycloplegic. So that should be like never under any no circumstances to give the IV potassium IV via IV push. And we have a very strict guidelines in terms of how much to give potassium, how many milliequivalent if you want to give it diluted IV drip. It's an IV drip, like how many milliequivalent an hour, like 10, max of 20 milliequivalent, an hour, and that's by the IV drip, not the IV push. So just keep that in mind. Never give the IV, potassium IV push, because that could result in a cardiac arrest, and the patient could die from that. So the calcium, another important electrolyte, which has a lot of functions too. You can read about them. What controls the calcium is the hormone called parathyroid hormone, PTH. So the parathyroid hormone controls the calcium level. And what prompts the PTH hormone to be secreted? Is it the hypo or hypercalcemia? When would you see more of the PTH hormone? Because the PTH hormone, the parathyroid hormone, is the one that is responsible for the control of the calcium. So I'll make the calcium level within range, which is right here. We said 9 up to 11. That's what makes that calcium to stay within that, within these ranges between 9 and 11. So what makes the calcium to be controlled under these numbers or these values? The PTH hormone. Let's say that, so what makes the PTH hormone to be produced in large amounts? Is it the hypocalcemia or the hypercalcemia?
The hypocalcemia.
Hypo.
The hypo. Always remember this, that the drop in the calcium level, anytime that the calcium level will drop less than 9, we will anticipate that there is a negative feedback mechanism. It's coming from the end. We'll discuss this under the endocrine system in the more in depth and in more details. The endocrine system, we'll cover this under that system. But the hypocalcemia, it will trigger more PTH hormone to be produced, because the PTH hormone has 3 specific mechanisms. It has 3 specific organs to pull the calcium back to normal and put it, and make it within range. So the PTH hormone, it works on the GI tract, on the kidneys, and on the bones, 3 different areas, in order to make all that effort to bring that and bring more calcium to the bloodstream and correct the hypocalcemia. So the PTH hormone, it will be produced in large quantities and amount in response to the hypocalcemia. Hypocalcemia. So patients with hyperparathyroidism, whose parathyroid glands are producing too much of PTH hormone, they tend to develop the hypercalcemia. So the hypercalcemia, either due to the increased PTH hormone, or due to the malignancy, cancer, or vitamin D overdose, or prolonged immobilization. Because with the prolonged immobilization, patient in bed for months or years, without any like activity and without any like special like program to increase the the activity and the exercise or exercise program, they will have a problem of that bone resorption, which is that the calcium will exit the bones into the bloodstream, and that's what makes or result cause this type of hypercalcemia due to the immobilization, because immobilization prolonged, especially prolonged, result in the bone resorption, which is that the calcium will exit the bones and go to the bloodstream. Manifestations, and then we have hypocalcemia. So we'll see more of hypocalcemia more than hypercalcemia in the hospital, with calcium level less than 9. And these are the causes of the hypocalcemia. Mostly it's due to, if not due to the parathyroid gland PTH hormone, it's due to the decreased intake. The manifestations, two main manifestations. One is called Shvastik sign, and the other one is Trousseau sign. And the Trousseau sign, which would be, you can elicit the sign, which is the carpal spasm of the fingers and the palm, and the hand, or the wrist, at the wrist level, which is called palmar flexion, in response to the inflation of the blood pressure machine. So when you inflate the cuff of the sphygmomanometer, manometer, that's going to result in the carpal flexion. And that's a sign of hypocalcemia. We call this Trousseau sign. The Shvastik sign on the other side here, it will, it's the twitching of the cheek muscle, or the cheek muscle in response to the tapping of the cheek. So tapping results in twitching and spasm of the cheek muscle. That's called Shvastik sign, and that's also a significant sign for hypocalcemia. Now, the last one, which is the protein molecules or protein imbalances. The proteins, either hypoproteinemia or hyperproteinemia. It's very rare that you will find, patients with hyperproteinemia unless they are on, let's say, TPN or total parenteral nutrition, or another, a form of nutrition intravenously, and they are like overdosed or taking like a large amount of that. But most of the cases you will encounter them in different healthcare settings will be patients with hypoproteinemia, malnutrition, patients with due to starvation. So the clinical manifestations would be the edema, fatigue, ascites, slow wound healing, another sign. So patients with wounds, we always recommend that we have to increase the protein level, because that's going to help with wound. It will enhance the wound healing and promote wound healing. So patients with sacral wounds, for example, or the cubitus ulcer wounds, so we have like protocol of things that patients should take. One of them is the protein. We will increase the protein level in order to enhance and to promote the wound healing. So what about if you review the questions and think about the answers, because I have to give you just the beginning of the introduction of the ABGs and how to analyze the ABGs, the acid-base balances or imbalances. Because that's important, because you have to practice on the some questions on ABGs. So let's start with the acid-base balance. So we have the regulators of the acid base. What makes the acid base, like what we discussed in under the fluids, and we said we have factors, we have forces that govern the fluid distribution and different components to be within range. Same thing here. That's we have regulators, or we have factors that govern the acid-base balance. So the three main factors, or the three main components of the regulation, it's from the buffers, lungs, and kidneys. Three main places. So pH, I'm not going to spend much on the pH because this is a pure chemistry. So the buffers, you can refer to the buffers as, in our a good, nice analogy in the mid-search textbook, it will refer to the buffers as a sponge. That the buffers can work in both media, it's acidic or alkaline, to equalize and to bring it back to balance or normal. So the buffer and what makes this first of all, what makes the main component of the media acidic versus alkaline?
Carbon dioxide.
Excuse me. I'm sorry, you said carbon dioxide.
Carbon dioxide, yeah.
No, it's one of the components that belong to the lung. Yes. Hydrogen ion, what makes the media acidic versus alkaline? The high number of hydrogen ion in the media becomes acidic. This is one of the very basic and very important, concepts and acid-base imbalances. Is that the hydrogen ion, the more hydrogen ion makes it more acidic. So the buffers and the buffers work in both medias. Acidic, it makes it more less acidic, and the alkaline makes it less alkaline. So try, because the buffers, whenever it's thrown into the media, is going to make it more balanced in terms of the pH. So how the buffers, back to the mid-search textbook, they talk about buffers as a sponge. That's if the buffer in the acidic media is going to suck more of that, so it will absorb the hydrogen ion from the media and then make it less acidic. And if the buffer is going to be thrown into the alkaline media, it's going to release these hydrogen ion in the media and make it less alkaline. So the buffer is good for both, to equalize, to bring the media back to normal pH, or within range pH, to be within range. And we have numbers for the pH, which is going to be 7.35 up to 7.45, and this is for the arterial blood levels. Arterial pH supposed to be between 7.35 up to 7.45. So the buffers, and we have a lot of examples of about the buffers, and as one of the controllers of the pH, or the acid-base balance. The other component, which is the lungs, respiratory system. So the lungs control the pH by doing two things. Either we can increase the rate of the respiration, hyperventilate, or we can, lower that that ventilation rate, and by what is called the hypoventilation. So the increased rate of respiration versus the decrease, that will be a compensation in response to the changes in the pH. So what's the significance of increasing number, or decreased respiration or decreased respiration? So what effect we have that this respiration has to do with the pH? How would you explain the hypoventilation or hyperventilation in terms of its relevance to the pH?
Hyperventilation increases the pH.
No, no, I'm
Hypo,
asking the hypo. Are you answering, Tewo?
yeah,
Oh,
yeah.
okay, good. Go ahead.
I said hyperventilation would increase the pH. And hypo,
Hyperventilation. Let's
yeah.
stick with that one first. When you say hyperventilation, means that the rate of breathing has increased.
Mhm.
Let's say that you breathe a 32 breaths per minute, blowing off CO2, right? You're going to blow off CO2. Lots of CO2 is going to exit from the bloodstream. So the CO2, look at the equation here. CO2 plus H2O results in H2CO3. What is that H2CO3? It's the carbonic acid.
Yeah.
Carbonic acid. So that's when you have accumulation of CO2, not you blowing off the CO2. So let's do the other one, hypoventilate. Let's hypoventilate and breathe at 10 breaths per minute. That's when you are going to retain CO2. Carbon dioxide is going to be accumulated and retained in the bloodstream and the vascular system, right? In response to that. So when you hypoventilate, you'll retain more carbon dioxide. And anytime you are confused or unsure about the hyperventilation, always remember that CO2 plus H2O results in H2CO3. The accumulation of the CO2 of the carbon dioxide with the water vapor in the lungs would make the carbonic acid. That's a resultant product from hypoventilating and accumulating the carbon dioxide in the lungs. Hypoventilate, retention of carbon dioxide with the water vapor will result in carbonic acid, acidic. So patient will develop acidosis from hypoventilation. What about the hyperventilation? Hyperventilation, then you will blow off CO2. You are not retaining CO2. You are going to have less CO2. So the acid makes the accumulation of the carbon dioxide make it more acidic, which would result from the hypoventilation, and the hyperventilation will result in alkalosis. Is this clear, or you want me to repeat it? Good. Kidneys, how the kidneys would control the ABGs or the acid-base balance, or keep it, keep the ABGs, the acid-base balance in different mechanisms. The kidneys, they have a control on hydrogen ion and have also a control on the bicarb. What makes the liquid or the media alkaline? Because of the bicarb. If there is more bicarb, excessive bicarb, H2CO3, then that makes it more alkaline. So if the kidneys retain bicarb, that would result in alkalosis or acidosis. Kidneys retaining alkalosis. Kidneys are flushing the bicarb out and losing bicarb, then that would result in acidosis. So there are three mechanisms in which that, three levels in which the kidneys can regulate the pH. It can move the bicarb in and out, excrete or retain. It can form some type of acids and will be released in the urine, and that will increase the pH, become more acidic. I'm sorry, become more alkaline. So pH, increase pH alkaline, decrease pH acidic. Or the kidneys can form what is called the ammonia, NH3, and that will bind with the hydrogen ion in the urine to increase the pH and make it more alkaline. So these are the three main, you can refer to that, to these three mechanisms in the book about the three main levels of how the kidneys control. But the most important one, or how the kidneys would control the pH would be mostly the hydrogen ion and the bicarb. Hydrogen ion released in the urine, then we have less hydrogen ion, which is a source of acidity, so the patient will become alkaline, or the blood become, or the plasma more alkaline. If the kidney retains the hydrogen ion, becomes acidic, pH drops. Same thing with the bicarb. Kidneys release the bicarb and the HCO3 in the urine, then the blood plasma becomes acidic or more acidic. And if the kidneys will retain the bicarb, then the plasma becomes more alkaline. So these are the numbers, and I think we have a few minutes left that we can just briefly go over the ABGs. So next time that we can practice more of these questions. So the pH supposed to be between 7.35 up to 7.45. PaCO2, the partial pressure of the carbon dioxide, 35 up to 45. Bicarb HCO3 is 22 up to 26. And then those are the main components for the interpretation at this level. We're not going to cover the PaO2 or the SaO2 because we will just focus on the three components: the pH, PaCO2, and the HCO3 as the three elements of the interpretation that is needed to do the interpretation of the ABGs. So when the pH is less than 7.35, it's called acidic. So just go to the interpretation. Take just one example and try to explain the in 5 minutes, just number one. So 7.32, which is, we know that the normal ranges, there is a sheet, like a sheet and the a table on the blackboard. You can just print out the sheet and try to practice on it. The pH is supposed to be between 7.35 up to 7.45. If the pH is less than 7.3, I'm sorry, the pH is 7.32. What is that, acidic or alkaline?
Acidic.
Acidic. So step number one, the first phase, step to do the interpretation is to identify to find out if it's acidic versus alkaline. So the pH will determine that it's acidic. And then we are looking for the matching component. So again, just ignore the PaO2. So don't try. So forget about the PaO2. Okay. So the PaO2, PaCO2 67, and then we have the bicarb HCO3 37. PaCO2 67, is it acidic or alkaline?
Acidic.
Acidic.
Acidic because it's more over 45. It's supposed to be between 35 and 45. So the higher the CO2, it's more acidic. Less than 35, alkaline. Over 45, acidic. Bicarb HCO3, and that's 37. Is it acidic
Alkaline.
or alkaline? Because it's supposed to be between 22 to 26. So it's higher than 22. So it's alkaline. Now, three components, again, pH, PaCO2, HCO3. So which one is compatible or which one is acidic? Because the pH is 7.32. So we are looking for the matching component to the acidic. Which one is, we said it's acidic. Is it the bicarb or the CO2?
The CO2.
The CO2. So the PaCO2, so again, we have pH, and we have the lung component, PaCO2, and the kidney component, the bicarb. In other words, the metabolic, the bicarb, respiratory, PaCO2. So the pH is 7.32, and the matching component is the PaCO2, which is the respiratory component. It's not the metabolic component. The one that is acidic is the respiratory. So this is a respiratory acidosis. Is there any compensation? Because if the respiratory, if the problem, in the lungs, or due to the lung problem, lung function or dysfunction, then the kidney is supposed to compensate to bring that back to normal.
Not.
So there is a compensation because the bicarb is higher than 26, supposed to be between 22 to 26. So the kidneys is attempting to bring more bicarb back to and retain more bicarb to correct the acidosis, but it's in the process of reaching the within normal limits of pH 7.35 to 7.45. It hasn't reached that that point yet. It's in the way to compensate, to bring that pH back to within range. So this is a respiratory acidosis with incomplete, or you can call it partial, compensation. So 3 levels or 3 steps to analyze the ABGs. You start from the pH, identify the pH, is it acidic or alkaline, and then find the matching component to the pH, which one is the matching component, and then you will find if there is any compensation or not. I may not focus much on the compensation at this point, but for now, just make sure that you understand how to analyze the ABGs without looking at the compensation. pH acidic, which one is is the matching component? Is it the PaCO2 or the bicarb? And that will give you an indication if the patient is developing a respiratory alkalosis or acidosis versus the metabolic acidosis or alkalosis. So we'll have to practice more of this in order to to grasp the idea and the concept of the interpretation of the ABGs. You need to practice more of that. So I think we can stop and do more practice next week when we meet on Tuesday, right?